So today I will take about the traumatic brain injury. So traumatic in the CCS, either you will get traumatic brain injury TBI case, and from that case will flow, or in the CBS also you will get a question from the traumatic brain injury when either in the curve or in the carbon loop or in the image table, where you will get in the curve you will get ICP monitoring curve, and where they might ask about the ICP monitoring, and also from there how will you manage traumatic brain injury, ABCD, and also you can get traumatic brain injury CT scan findings, extradural, subdural picture. So let us start with the okay. Yeah. So now the first variant, 28-year-old male on the motorcyclist was not wear the helmet and is brought in the high-speed road traffic accident. GCS E2V2M4 8/15. Blood pressure is 86/54 mmHg. Heart rate 126. SpO2 88 on NRBM. Pupil 5 mm sluggish. Left 3 mm reactive. Airway, blood, vomiters on the oropharynx. First scan negative. Chest X-ray, no pneumothorax. Then the question here, this what is the your immediate resuscitation priority? Describe your airway plan, and which induction agent would you choose and why? And how will you prevent secondary brain injury during intubation? And what are the post-intubation goal for oxygenation, ventilation, and perfusion? So, who want to participate on the discussion? Anyone can come. Priyanka, you are ready today? Nidhi? Any one of you can John? Chakao?
Yeah,
Yeah.
I can. Let me start.
Yeah. So
Yeah,
John,
so this,
let me tell me about the answer of first question. How would you go for immediate resuscitation priority?
okay, I will apply the ABC
Yes.
resuscitation method this patient, because GCS is already compromised 8/15, and the patient is also hypotensive. So I will ensure the airway is patent, and clear the airway. There's already vomitus and blood in the oropharynx. So open the airway by suctioning and clearing, and then proceed. Breathing is very likely he may have aspirated because of the reduced GCS. So I will proceed to secure to intubate these patients, and then start saline resuscitation for him. Okay, so that would be the priorities as far as resuscitation is concerned.
Okay. So you mean to say that you want to first intubate this patient because the GCS is 4, GCS is 8/15. So your threshold is GCS 9. And also why you will intubate, because the hemodynamically compromised and there is a blood and vomiters in the oropharynx. So there is a chance of aspiration. So that's why
Yeah.
you want to intubate and secure the airway, then breathing, then circulation. So in EDIC exam, always you start with A, B, C, D. Okay. So now next question. Next question is and next what will you do? So describe your airway plan. You have rightly described that you want to go for intubation. And
Okay.
next question,
Okay.
which
Yeah, my
induction
plan
agent would you
for
choose and
preparing.
why?
Okay. Um, for in this patient, I I can use because of the drop in blood pressure. My plan would be to, of course, to start crystalloid resuscitation immediately to try to bring up the blood pressure. Then I will, of course, the intubation or airway, securing the airway will be by
So ideally,
rapid
the
sequence induction.
induction agent should be which does not cause hemodynamically instability further. You can't use propofol in this case. You can't use
Yes, exactly.
propofol, but you can use the etomidate, or you can use the fentanyl and the benzodiazepine, which has minimal uh, effect
Hypertensive
on
effect.
minimal effect on blood pressure, and
Pressure.
also benzodiazepine has some brain protective effect, and it reduces the seizure potential. And how will you prevent secondary brain injury
Yeah.
during intubation?
Um, well, by ensuring that the patient is adequately ventilated, so and is adequately oxygenated. Oxygenation is the one important step to prevent secondary brain injury, and that is the reason why and to
So
oxygenate him, I
secondary
will need
brain
to
injury,
apply
you have
rapid
to
sequence
avoid.
induction.
So secondary brain injury, you have to avoid hypotension, you have to avoid hypoglycemia, you have to avoid hypercarbia. So this three is the main thing, and you have to prevent the seizure. So if there is a high ICP also, and you have to বস একটু 10 মিনিট বস। So you in the secondary brain injury, and you have to reduce the ICP. So for reducing ICP, you have to do the good sedation and paralysis. Otherwise, if there is a cough reflex, it will cause your increased ICP. So what are the post-intubation goal? Oxygen and ventilation and perfusion.
Okay. Well, my post-intubation oxygenation goal will be to maintain PaO2 level of at least 75, PCO2 level between 35 to 40, and then ensure that and perfusion target will be to achieve a lactate level of less than 2
Yes.
by ensuring adequate perfusion, adequate fluid administration.
So perfusion means you have to maintain the perfusion pressure of the brain, and
Oh, okay,
you
okay.
have to
MAP
increase
of
the map
perfusion pressure.
to maintain the perfusion pressure. Normally the perfusion pressure is around 65, so you have to keep map more than 75. That's actually asked. Now it is the model answer. Priority follow ATLS ABCD simulation. So it is a trauma case. So
Okay,
first you have to utter the cervical spine immobilization,
okay,
correct hypoxia and the hypotension. Then your A is the airway, because it is a trauma patient, low GCS. So you have to do intubation and also vomit and the blood is there. But you will follow the protocol of RSI, rapid sequence intubation, with manual inline stabilization. Avoid nasal route here. You go for the oropharyngeal intubation and ensure pre-oxygenation, because hypoxia can cause the secondary brain damage. Okay. Now, induction agent, I said, I have mentioned that etomidate will be the ideal, because etomidate will not cause the uh, blood pressure instability, and propofol if stable. So if the blood pressure is unstable, you can go for the etomidate. If blood pressure is stable, then go for the propofol. Why? Propofol has the brain protective effect. But if our patient have a low blood pressure, so etomidate will be ideal choice. Then fentanyl, rocuronium, and you avoid thiopental, because thiopental causes hypotension. So any agent which causes hypotension, you have to avoid during intubation. For secondary brain prevention of injury, you are using the lignocaine and fentanyl to blunting the cough reflex, and also you are blunting the hypercapnia, also you avoid the hypercapnia, hypotension, and maintain MAP more than 80 to maintain the cerebral perfusion pressure. So target of your SpO2 more than 95%, PO2 more than 100, PaCO2 35 to 40, and blood pressure, systolic blood pressure more than 110. So this is your marking system of this question. Next, coming to VNN 2, CT scan brain, you have done the left temporal contusion, thin subdural, 6 mm midline sheath, compression, basal cisterna, EVD inserted, ICP showing 26 mm HG, MAP is 82, perfusion pressure 56, and ABG showing the PaCO2 38, PO2 110. So the question is, what are the initial ICP lowering measures? Define the targeted ICP and CPP, and how will you optimize cerebral oxygen delivery? Which sedative analgesic regime prefer, and when do you involve neurosurgery? So first question, please.
Okay. Okay, should I go ahead?
Hi.
Can I go ahead? Should I go ahead and answer?
John, tell me.
Okay.
So today is the day of John's
okay.
day. So please
okay.
let him express his
Oh,
thought.
okay. All right.
Thank you,
Thanks.
sir. Yeah.
John,
Okay.
yeah.
So my initial ICP lowering measures
Yeah.
will include positioning the patients
Very good.
with
So head up position, make neck straight.
30 degrees, 30 to 40
degrees,
45
yeah.
degrees ahead of
Yeah.
position. Okay. Yeah. Okay. And then ensuring an adequate sedation of these patients, and possibly including a muscle relaxation. Okay. And okay. Okay. For now, that's those are the principal ICP measure lowering
Yeah.
measures.
So
Sedation
the ICP
preferably with
lowering
fentanyl
measure,
and
one is the sedation paralysis, neck straighten, and you have to give some because the ICP is 26, so high. So ICP lowering drugs you have to give, either mannitol or concentrated saline, 3%, 25%, or 10%. Define target ICP and the CPP. What will be your target ICP and what will be your CPP?
Okay.
So
My
yeah,
target CPP, uh,
yes,
my target cerebral perfusion pressure will be 40 millimeters of mercury
no,
minimum.
no. CPP is around 60 to 65. The cerebral perfusion pressure is 60 to 65. And what is CPP? CPP is the MAP minus ICP. Okay. So here
Yeah.
is your MAP is given 80 and your ICP is around 26.
Yeah.
So
Okay.
26, so CPP is coming to 56. So you have to increase the CPP around 65. So you have to reduce your
The
ICP little
ICP.
bit. Okay.
Yeah. Yeah.
And how will you optimize cerebral oxygen delivery?
Um, Still by well by okay, when we can increase increase FiO2 to ensure that
So PaO2
the
is
PaO2
PaO2 is already see
100. Okay.
PaO2 is 100. Oh, sorry. So PaO2 is already is given, na? PaO2 is
Yeah.
110.
Okay.
We can use oxygen map augmentation, sir.
Yeah. So you have to maintain the perfusion pressure. You have to reduce the
Okay.
hypercapnia and all. And which sedative analgesic regime you will prefer?
I'll prefer propofol with fentanyl.
Okay. And when do you involve neurosurgery?
Okay. I'll involve the neurosurgeons if the ICP exceeds, if it exceeds 25, I'll notify the surgeons to
Okay. So if you measures all the ICP
consider opening the
lowering
skull.
measurement, still the ICP is higher, then you have to ask for the neurosurgery for decompressive surgery. Decompressive surgery. Now it is a model answer. ICP control, head up 30%, neck neutral, analgesia, sedation, especially propofol and fentanyl, normothermia, normocapnia, and osmotherapy. Osmotherapy include either mannitol or 3% normal saline. Your targeted ICP is less than 20 and the CPP is 60 to 70, is around 65. That is the Brain Trauma Foundation 2023 guidelines. And how will you increase oxygenation? Maintain SpO2 more than 94%, maintain hemoglobin 8, avoid fever and optimize carbon dioxide. So
No,
optimize
cardiac
cardiac
output.
output. So why it is important? So the oxygen delivery depend upon your cardiac output and the oxygen content in the blood. So what is the formula for oxygen content? It is called CaO2. The oxygen content in the blood equal to the percentage of saturation, the SpO2 into hemoglobin into 1.34 is the ml oxygen saturated in the hemoglobin. So if you want to increase the oxygen content in the blood or DO2 in the blood, so you have to optimize the hemoglobin also. Now coming to sedation, what sedation you will give? Propofol, fentanyl preferred if hemodynamically stable, because and here is avoid benzodiazepine early, consider neuromuscular blockade if refractory ICP. Why you are avoiding benzodiazepine? Because benzodiazepine cause the initially it is suppress the GABA, but it has a refractory effect which ultimately need higher dose of benzodiazepine, but it is not effective to this GABA receptor. and the most of the benzodiazepine can cause the hypotension also, except midazolam. So therefore propofol, fentanyl prefer, and propofol also it reduces the brain metabolism. So it reduces oxygen consumption, therefore it reduces the secondary brain injury. When you will call neurosurgery, if the mass lesion or ICP more than 25 or midline shift more than 5 mm, despite of tier 2 therapy. Okay. Now coming to the next scenario. Next scenario, despite sedation, hypertonic saline ICP is 30 mmHg, more than 1 year, 1 hour, and CPP is 58, still lower side, and PaCO2 is 36 and PaO2 is 120, no mass effect progression on repeat CT. Now question is the outline tier 3 intervention.
Sir, the tier 1 is head end of the bed elevation, giving adequate analgesia and sedation, maintaining PCO2 between 35 to 38 millimeters of mercury, avoiding fever. And tier 2 is starting the hyperosmolar therapy to maintain serum osmolality of above 290 milliosmoles per liter, or hypertonic saline to maintain serum sodium above 150. And then we can in tier 2 there is also map augmentation strategies being used, like vasopressors to maintain an adequate map and cerebral perfusion pressure. And then the PCO2 goal is 32 to 35 in tier 2. And in tier 3 there is lumbar CSF drain with hyperosmolar therapy, and surgical decompression can also be considered. And the last one, tier 3, we can also use therapeutic hypothermia and decompressive craniotomy. Sir, we are not able to listen.
I was mute. Now I'm audible.
Yes, sir. Yes, sir.
Yeah. So tier 3 is what happened? Lung protective ventilation. Where we are? Oh, venient road. So tier 3 is barbiturate coma. You are rightly said. Decompressive craniotomy, mild hypothermia, drainage optimization, and transient ventilation. These are the tier 3. Now, the next question was the define target ICP and CPP. So, the ICP, sorry. The next question was discuss about the decompressive craniotomy. So indication, timing, and evidence. So refractory, if there is a refractory ICP high more than 25, more than 1 hour, despite your tier 2 and tier 3 therapy, then you have to go for the decompressive craniotomy to reduce the mortality, but disability will be there. It can reduce the mortality, but not the disability. Now, what is the role of barbiturate command? You may ask about the how it's work barbiturate command. So thiopental 3 to 5 milligram per kg per hour to brush suppression require hemodynamic support. So what actually do thiopental coma? That it reduces the brain metabolism is nearly brain metabolism reduces nearly is 0. So the oxygen consumption will increase very significantly, and therefore there are chances of cell injury is anoxic injury is lower. Now, hypothermia, it is a controversial, no functional benefit. And next question is hypothermia. How much hypothermia? Actually, hypothermia, it increases the shivering, and which shivering ultimately increases the oxygen
Oxygen
consumption.
requirements.
So it is detrimental. It causes secondary brain effect. So if you give hypothermia, it should not be less than 35 degrees Celsius core body temperature, because it has shown that there is no much benefit on the hypothermia. Now coming to the next question, how will you evaluate cerebral autoregulation? So cerebral autoregulation evaluate your correct ICP and the map. So you maintain the perfusion pressure, and transcranial Doppler you can do, and transcranial Doppler what you will see the flow velocity will help to understand the autoregulation. Now coming to the variant 4, day 3 develop hypoxia. So you have done the craniotomy of this patient, develop hypoxia, PO2 FiO2 160, bilateral infiltrate, ICP is still 24, and the temperature 38.8 degrees centigrade, culture pending, chest x-ray, there is a lung contusion. So ventilation strategy to manage lung injury without worsening ICP. So again, in critical care, always in the ventilator strategy, be it lung injury, be it ARDS, be it trauma, always utter that lung protective ventilation, low tidal, high PEEP, and maintain FiO2 to maintain SpO2 more than 92%. Because it is a traumatic brain injury, so our carbon dioxide target will be 35 to 40, and here we will avoid permissive hypercarbia, because hypercarbia is cause secondary brain injury, and also you can't give very high PEEP, which again it increase the your ICP. So how will you control temperature? Control temperature by surface cooling or by your strategic point cooling, like ice on the inguinal region, axilla, or you can use the paracetamol. And next, how will you differentiate septic virus, neurogenic fever? Anyone? Septic virus, neurogenic fever? So again, in septic fever, there will be high biomarker like increased CRP and procalcitonin, the TLC. But in neurogenic fever, there will be the biomarker is normal, and then it is a neurogenic fever. Especially if there is a putamen bleed, then there will be high temperature. And discuss the sedation analgesia strategy in this page. Again, so here this is the third day. So you reduce the propofol use, and you can use the dexmedetomidine to ensure analgesia and the sedation, and you are planning for winning strategy here. So what will be your fluid and vasopressin target here? So again, the crystalloid fluid is preferable, isotonic balance solution, and avoid hypotension, avoid hypo or hypoosmolar fluid like dextrose containing fluid. And second, your targeted map will be to maintain your cerebral perfusion pressure. So targeted map will be 80 because ICP is little high.
So we should use normal saline. No? Yes.
Normal saline you can use, but this is in the resuscitation you can use the normal saline, and the brain. For brain, you can use the normal saline is the ideal choice, but when it's come to maintenance, you can use the balance or solution, not initially. So the model answer is like that. The fluid and vasopressure, isotonic balance crystalloid, avoid hypoosmolar is the main thing. For your, if you want to say the normal saline, it will not have the negative marking, but you have to utter the avoid hypoosmolar. The examiner want to know the avoid hypoosmolar things, and MAP should be more than 80% to maintain the CV, your perfusion patient. Now coming to day 7, ICP control, sedation stop, GCS E3, VT, M6, 90, moving all limbs, CT stable, family asks about long-term recovery. So how will you assess neurological recovery potential?
So neuroprognostication, it should be done 72 hours after the
तो अभी तो 7 days है ये पेशेंट का तुम्हारा आईसीपी कंट्रोल हो गया एंड जीसीएस इज अराउंड 90 तो आप न्यूरो प्रोग्नोसिस बनाओ बोलो
Sir, we should wait for 5 half-lives of the sedative drugs to settle and then
Absolutely. So you should wait for the sedative age effect overcome, and you should do the what you can do. You should do the neuro examination, and also you should do EEG, MRI, or evoke potential, and the neurological exam is always if the patient obey command or if a patient moving limb then has a good prognosis or if the MRI showing that the damage in the brain or evoke potential is poor result then still the ICP is high then it will be bad prognosis so you have to prognosticate and here question is which prognostic model are validated in TBI. So you have to name some score here. So there is a two model, one is impact model and other is the crash score use in the they use the age, GCS, people, city, brain and the physiological changes and they give you the score and according to the score this poor prognosis or good prognosis and then what rehabilitation measure will you initiate.
lymph
So
physiotherapy.
remember from the TBI, either the patient go home with the rehabilitation facilities or patient having the scenario having the traumatic brain injury to brain death and organ donation. Okay. So you will be prepared in the CCS from the both the way. So regarding the rehabilitation, you will say that what we do the physiotherapy, good physiotherapy, nutrition, and then we are plan to send the patient home with the support of physiotherapy and need family education. These are the things we have to utter here. And how do you communicate prognosis in the family? So again, it is a ethics question, ethics communication question. You have to be very honest about the prognosis. You have to be empathic and you have to discuss what you have and what evidence is about the prognosis. Now coming to next question on the ethical question regarding the outline of ethical principle end of life discussion making TBI. If the patient having the brain death kind of condition, then if you want to say the end of life, and how will you proceed? So actually here you have to tell the respect autonomy of the patient and non-malification, then follow the end of life guidelines, and you have to take a multidisciplinary input. So ideally, you will tell that as per the guideline, end of life guideline by EDIC Society or ULC, that ESICM Society, that we will do multidisciplinary discussion about the poor prognosis. Then we will tell the patient family that this patient is no more quality of life, or there is a chance of non-recovery. So you can go for the end of life condition, end of life support. So these two impact and crash course, please go through this, because they can ask about your impact, and then they can ask about the prognosis. And here from the case might go to other scenario like your brain death kind of scenario. So I can do the brain death scenario tomorrow because I was stuck in a meeting. That's why I get late. So I have another work pending. So excuse me today. Tomorrow I can take this next variant where we will go to the brain death testing and all. Thank you.
Thank you, sir.
Fatma.
Hello. Yes,
Yeah.
sir.
So
You can.
the next part is the brain death scenario that I will take class tomorrow,
Okay.
because there is a huge trying crisis for my side. I was stuck in a meeting, that's why I get late. So I have to do a lot of work pending. So sorry for that. Tomorrow again we will meet. So you are giving tomorrow or day after tomorrow?
I don't think that tomorrow or day after tomorrow will be possible, as we are starting our crash course from tomorrow onwards. And
Oh,
also we are having tomorrow at 12:30 p.m. also in urgent basis.
okay.
So maybe the class will be possible after 10th November.
Okay, okay.
Okay.
So
Thank
after 10th, for neurology section, I will take traumatic brain injury, and sorry, end of life. I will take the other area like meningitis and the neurological other things. I will inform you what I will take. And how many of you are giving exam this year, this November? Sana, you take a separate group who are going for the exam this year, and we will have little bit discussion, little bit CVS and CCS. We will next 15 days or next 20 days we have for the exam. So I think most of the exams started with the 24 and 25. So we will have a separate group for exam going. And if you have any question regarding the ECG or regarding the curve loop, you can put in the group, or you can discuss among yourself. I will be mentoring this group. So if you need any discussion, any class for next 20 days. I can help you out. So Sana, though we have a group for only those who are appearing in the November 24 and 25 exam, please do separate group. Sana.
Sure, sir, I will.
Okay. Thank you.
Thank you, sir.
Thank you.